case study number 3, Shalom, we know the format. We know how that works. We know about the BMP and the CBC. All right, so going in cold like this is an easier way to understand and dissect what's happening now. All right, so labs are first. So we have sodium, and we see right here, right away at the very beginning, there's more than the BMP and more than the CBC. So we'll put those in there. And the first thing we have sodium is normal, potassium. Okay, so this CO2 right here is abnormal. All right, so that's a first red flag, and this is the boat coming, either renal or pulmonary. So I'm generally will be thinking of that. It's usually respirations, so oxygenation and respirations, right? So that's the first thing. Okay? So chloride's okay. Now, the basic principle is that this is abnormal, that patient, think of a high heart rate about the 88, all right? Once these are both there, you think mid-90s on a heart rate. It doesn't mean that it means that, it's just a thought process. B1 creatinine normal, pointing over here, diabetic or pulmonary things going on with this patient. We have an elevation of a white count, so we're going to think, okay, is this an infection? But it's a low grade, right? So low grade, it also could be inflammation. Generally, it's not always infection. Remember, 72 hours would be infection, depending on where we are in the conversation. So this is a low grade. What I would generally do is I would like to see a differential. And we talked about that last week where we said never let me eat Brussels sprouts. And where I'm going to really differentiate is this what type of infection is causing this elevation. So if it is an infection like antibiotics related bacteria, it would be the neutrophils. Right? Everything else is usually cancer, histamine responses, or something else going on. It's not a pathogen. That's questionable, so we keep on moving through. Okay, this is normal. So then we think about the organs, right? Okay, any renal, coags, liver, and cardiac. I'd expect renal because of this 160. Question in diabetic, I'm not sure though, I need more data. And then I have a renal diagram. Now it's not a severe renal diagram because I would have all 3, and I don't, right? So I don't have the phosphorus there, so it's not a chronic renal patient or a hemodialysis patient. Right? So if I had a hemodialysis patient, I'd be looking at that phosphorus, which we talked about earlier today about phosphorus binders. I also have liver enzymes, which is characteristic, okay, statins, or something else is going on. We're evaluating the functioning of the liver, so I'm not quite sure, so keep on moving. They're normal though, there's nothing there. Oh, this is interesting. So I have coags being drawn. I don't normally just draw PT coags unless there's something in relationship to coagulopathy, like somebody who's bleeding or somebody who might have a PE or might have a DVT, or we might have to administer some sort of anticoagulants. So I need the baseline of to come in. All right, but this is okay. I mean, it's 10 to 13. I mean, it's okay. So this is baseline medication, baseline labs. All right, so I move on further and go down here. And I see cholesterol, right? So that's high, yeah, okay. Well, I would expect them, if I see high here, I would expect some sort of nystatin, some sort of simvastatin, nystatin. Simvastatin or atorvastatin, some cholesterol medications. Why? Because it is low down here. Now this is mildly high. The cutoff is about 150 though, but they've been changing that. So that's the LDLs. And the HDLs, you can't really raise by medication. All right, so it's just the way that your body deals with that. Now it's interesting to me that if you have liver enzymes, you also have this. Now PT is responsible. Prothrombin is made in the liver. Okay, so that's important to know. So if you see that a lot of times if they're questioning liver issues, they'll look at the prothrombin time. So, for example, if a patient has liver disease, they'll have an elevated prothrombin, right? But they don't. They have a normal one. So moving on, need more data. So it's not enough here. I see an ASED rate here. Now, an ASED rate is E35, right? So up to 35 on a ASED rate. 0 to 35 in inflammation. Okay, so if I see an ASED rate, there's an inflammatory process going on because I don't normally draw a ASED rate. All right, so if I'm looking for inflammation, that's what's going on, and I also see that. Okay, well, that's also confirming this elevation that is more leaning towards an inflammation of some sort. Doesn't mean it's an infection per se. All right, so let's keep moving and need more data. We also have the RBCs here, and we said earlier, 45 to 55, right? So 4.5 to 55 is RBCs. All right, so what meds do we think? Okay, so I would look at this patient and, I'm thinking cholesterol meds. I don't know. I think it's inflammation, but I need more data, so I don't have enough information of this patient. Now, you've already done this case study, so you know the background, and I've done it too, but I always like to go into it blind, like talking like it's blind, like I don't know what's going on. All right, so glucose, okay, well, I would expect maybe some oral glycemics. I don't see a hemoglobin A1C, so I think that maybe this patient might be a recent diabetic or anything like that, diet controlled, or it just doesn't make sense. And this is probably due to inflammation or breathing issues. But let's see more data. So we move into it. Okay, so we got glyburide. Okay, so that makes sense. So I do this symbol every time I see this medication, any kind of medication like insulin or glyburide or metformin. You just write this symbol, you box it, then you say to yourself, that's a 2, right? If you saw insulin, you write 1, but you're not sure, right? So we don't know yet. We're still trying to think about that, right? We don't know. Just because they're on insulin doesn't mean they're diabetic, because they're in the hospital. So they might just have insulin while they're getting coverage, right? Because they're on high dose steroids or something like that. So we don't know that data. But if they're on glyburide, they're type 2. They're not and we said that before, type 2 are DOAs, right? Dead on arrival, oral glycemics, activity level, and diet. Most important being diet and activity level for treatments, where type 1's a die. They'll die sooner than a type 2. Diet, insulin, and exercise. Insulin is the most important for diabetics. That's why we monitor the hemoglobin A1C for those patients. All right, so let's move on. Somebody asked me earlier about hemoglobin A1C within 90 days, and that's because the red blood cells live in the body for 90 days to 120. And so when you're looking at hemoglobin, there's 4 heme groups. So this is oxygen, CO2, but we're really talking about 3 to 5% is a big glucose molecule that's sitting onto this red blood cell. It's not carrying oxygen. So you or I have this going on right now. We're 3 to 5. So we're not carrying oxygen. Now, if we start to run away from the beer, oxygen has an affinity for these red blood cells and they bounce off. Okay? So you get that extra ability to get oxygen when you need it. So, but if you're just a sedentary person and you're at 7%, like greater than 7, you're just hanging around and you get 7% of the hemoglobin has sugar on it. It means it doesn't have oxygen on it, which is a big problem. That's where you get the neuropathies, all those types of things. All right, moving on. All right, what diagnostics do you think we have? Doppler studies, okay, so Doppler studies. So that makes sense because I was thinking, this information and stuff like that. So no flow to the left tibial vein, okay, so it's definitely positive, normal flow, right lower extremities, normal flow, DVT from the level of the column. Okay, so positive for DVT on this patient. Now, the interesting thing, I get this here, we talked about this briefly yesterday in class about Willie Dick heparin, right, helps. And the reason that's important is because of this right here. So when you start to see this factor 5 deficiencies, and when you start to see with PTT and bleeding, you'll see here that there's a factor 8 deficiency. See right here. So, so if there's a factor 8 deficiency, this is when you start to have von Willebrand's and hemophilia, and that's what we're talking about with it. It's very important to understand because when somebody is anemic, is it one of the factors being played with this? All right. What we're talking about with factors is the clotting cascade. Now, the clotting cascade is if I had a clot and I had an injury to my tubing, right? You need to form a clot on this, right? Well, first thing is use your platelets, right? Your platelets are platelet aggregation, right? And they sit and then they start to form that clot. We see that with coronary vascular disease. Remember with low dose aspirin? Well, low dose aspirin prevents those little micro clots forming on the side of the vessels. So, antiplatelets, right? Aspirin, that's what it is. So it prevents this platelets from binding on it because that's a natural circulatory mechanism that is going around forming clots. All right, so then you have what's called a clotting cascade. It's a fancy word for just basically means that all these factors in here, this is called 10, this is 12, 11, and 9. Then you go to factor 10. Just pay attention, don't write this down. 8, 6, 5, 4, 3, 2, 1. Okay? So these are factors. And when somebody, this whole area is required for a clot. Okay? You can't form a clot unless you use all these factors. Okay? So, for example, if somebody has a factor 5 deficiency, like Willie DeKepperhelps has a factor 5 deficiency, they're going to bleed because they can't form a clot. So if somebody has a factor 8 deficiency, they can't form a clot. Okay, and that's it. That's all that means. There's some autoimmune system that they just don't have these factors from genetic parents or whatever. So then what happens is that they can't keep on forming a clot. So how this works is in DIC is massive clotting everywhere, okay? And so what happens is every hole is forming a clot. So it goes platelets, 12, 11, 7, 9, 8, 6, 5, 4, 3, 2, 1, clot. Okay? And that's kind of how it works. That's one way it does, and it keeps on doing this over and over and over again. That's why DIC is a problem. That's why sepsis is a problem. You only have so many clotting factors. So if you have a deficiency, and that's why they're checking that, you're going to have problems clotting, right? And that's what they're talking about. So pretty fascinating. I mean, it's nuts to know. I mean, this is clotting, this is high acuity stuff, but it's kind of cool stuff. I mean, we'll talk more about this, and this is good that you're getting it now because we'll bring this back up when we get to sepsis and why a person bleeds out when they have sepsis. And the reason they bleed out is because of they had mass injury in all their vasculature. So all these clots are being formed all out. The next thing you know, they use them all up. You only have so much factors. That's it. So you have to give them fresh frozen plasma. You have to give them clotting factors and stuff like that. Platelets, because they use up all their platelets as well. All right. That's nuts to know. Big digression, but whatever. All right. So moving on, we go into, so we got a coagulopathy here. And that's what they're talking about with the positive proteins. Proteins are necessary for clotting factors and initiation of that clotting cascade. You also have a homocysteine, which is also a relationship to clotting and inflammation. Then you have a bilateral venous Doppler with positive left lower leg DVTs. Okay, so these will always be boxed because they are diagnostics. All right, so moving on, what do you assessment do you think? Well, I think they're going to have DVT stuff. That's it. And that's what I would expect. So I see right here, I see temperature. Okay, well, that's inflammation down here. I have a high heart rate. Well, inflammation, pain, all that stuff. I don't see respirations going up too high, which is weird. But blood pressure seems okay. And he's on Lumiere. Okay, so I have wheezes at the bases, which is interesting. But that might just because of there's no other data that's showing me this here, so I'm not quite sure why the wheezes are showing up on this patient. So I need more data for this patient for that, and I have a positive. So I'll just basically, this is wheezes bilaterally with positive DVT with lower left leg edema. That's all that means, okay? It's just a visual thing I can just say without having to write all this crap down, So I just do a little symbol, and I just basically do this. And, if they're obese, I do this on the person, okay? So I don't have to write anything down. So I could drop this paper. It doesn't make sense to anybody else but me. All right, so we keep on moving. What history do you think they have? Okay, well, I mean, if it's DVT, sedentary, there's nothing else that's really showing here other than maybe the diabetes here, but I don't know. So then I go in. Okay, so what do I see? I see, okay, he's a smoker. All right. Now this symbol right here we talked about. Okay, so this is what this symbol is. This is psych. This means that they're either crazy or they are in withdrawal, or this is potential for withdrawal. So if you think of a old school jug of booze, right, XXX, and so what I generally will do is at risk for DVT, delirium tremens, or DTs, I generally do this with my symbol. So this is psych. This is a potential psych because of alcohol. All right, so they're at risk for me that this person might go to alcohol withdrawal, okay, without having to write all that crap down. So what I basically do is I just write this symbol here. And, you know, generally I always usually write this. If somebody is in DTs, you know, I'll write that symbol. And I don't need to know, I don't have to write DTs, all that stuff, or, you know, schizophrenia. Like, I'm taking care of the patient for 12 hours. I know who they are. I don't need to write it. It's just a reminder to me when I'm giving a report, okay, as a trigger. All right, so moving on. What else do we got? Let's pull it all together. I mean, it's a DVT, so it's just going to be basically he's an overweight, so he's overweight. He's at 58, swelling his left foot, ankle, pain, 6 days. The pain's been getting worse. Okay, no kidding. Ranks pain on 8, made an appointment today with a primary care. Okay, so open and shut case, right? I mean, what's the treatment? Okay, well, there's several treatments, right? Well, we have the PT-INR. This person could get a PTT, and then we get a baseline, 25 to 35 seconds. And then what we'll do is we'll start them on that heparin drip. We'll bolus that heparin, and we're going to look for it to be 1.5 to 2 times whatever that was. So if I keep it simple, if I had 25, I want it less than 50. Okay? And I want it 1.5. If I had it at 60, I would stop the heparin drip, and then I would recheck it after a certain amount of time. All right, so then what would happen? Do I keep him on the heparin drip? No, I will then bridge him to Coumadin or to Lovenox or something like that. And a lot of times what we'll do is we'll send them home with our Lovenox stack, which they'll take, you know, Lovenox like for 5 days or something like that. And every treatment's a little bit different, so don't quote me on that. But they'll go out home with Lovenox, and they can do self-administration of that. Or they'll be on Coumadin, right? And they might bridge them to Coumadin. So how we bridge is once we're therapeutic here, we stop the Coumadin while they're on the heparin. Once they're on the heparin, once they're on the Coumadin, we will monitor the INR until it's therapeutic. Once it's therapeutic, then we stop the heparin, and then they go home on that. Right? And that's it. They need teaching and so on. So that's DVT in a nutshell. No coat. Yeah.
Do you?
What's that?
You don't have to taper them off heparin. You can just take them off completely, right?
Stop it. Yeah. Again, no code status, so thanks for that. And then what are the 3 things? You know, I mean, you know, what's this guy's coagulopathy? So, I mean, you know, hematology might be consulted because what's going on with this guy? You know, is it just a sedentary thing? What is it? You know, why does this guy get these DVTs, and what's really going on, and what's going on with this alcohol? You know, so I don't know. We'll check it out, see what happens. You know, he's at risk because of the alcohol with this and this, and so why would he be readmitted recurrent DVTs? You know what I mean? And then go from there. All right, so this is that, right? So DVTs here, you know, common sign erythemia, warmth. And then we have bed rest. We keep them bed rest so we don't mobilize that thromboembolism. We elevate the extremities, anticoagulants, Tylenol. We treat the pain, heparin, Lovenox. We if they can. So this is something I haven't talked about. So if you have a patient that, you know, can't get Lovenox because of risk for bleeding, we'll put SEDs on them. Okay, and that's why. So if you see SEDs, you know they're immobile they can't get heparin or Lovenox. Okay, and that's why they're at risk for bleeding. So SCDs are given for that. We'll do that a lot of time with septic patients. Okay. All right. So what else we got? Then we'll talk about this when we get to pulmonary embolism. All right. So there's yes.
Once they have a DVT, you take the SCDs off, right?
Yeah. Because it's just like massaging the.
Because we always take them off if it's like suspected. They're like, get it off right away. Okay.
Yeah, right away. Yeah, because that's why you never tell them to massage their calves and stuff like that, because they can mobilize that clot and it becomes a pulmonary embolism.